exactly, when we look carefully at the V1, we see that at some beats there are missing P waves. Some are with retrograde P wave, some are missing P waves. So this makes it this SVT or supraventricular tachycardia very unusual, and I would like to share some thoughts about this special group of patients. Now, narrow complex tachycardia with VA dissociation, there are fewer atrial depolarizations than ventricular depolarizations, and the tachycardia can continue without the participation of the atrium. That is, the atrium is not part of the tachycardia circuit. So with that, it immediately excludes two mechanisms. One is atrial tachycardia. The other is orthodromic reciprocating tachycardia, or what we call ORT, via an atrioventricular pathway or a conventional accessory pathway, because atrium is a mandatory part of these two tachycardia circuits. Now, what are the differential diagnoses of narrow complex tachycardia with VA dissociation? It could be atrioventricular nodal reentry tachycardia, AVNRT, with an upper common pathway block, ORT via a concealed nodal ventricular or nodal fascicular pathway, a junctional tachycardia, upper septal idiopathic left ventricular tachycardia, or intrahisian reentry, which is a very rare phenomenon. Now, in diagrammatic representation, we can see that for nodal ventricular or nodal fascicular ORT, the accessory pathway acts as the retrograde limb of the tachycardia circuit, and the block is in the AV node. In AVNRT, the block is in the upper common pathway. Intrahisian reentry and upper septal idiopathic left ventricular tachycardia, because the circuit is in the vesicle, so the ventricular tachycardia is of narrow complex, and junctional tachycardia, and the block again is in the node. And you can see that out of these 5 differential diagnoses, one is VT, the other all are SVTs. So step 1, how to differentiate ventricular tachycardia from supraventricular tachycardia. For VT, upper septal idiopathic left ventricular tachycardia, the His ventricular interval during VT is shorter than in sinus rhythm. That is, the HV in VT is less than the HV in sinus. Now, the HV interval in sinus is a true interval, but the HV interval in VT is a pseudo interval, as there is retrograde activation of His bundle, and there's no actual linear conduction from the His to the ventricle, so it's not a true interval in that sense. And the second, we have to look at the His bundle at baseline. If there's absence of a split His bundle, His potential, that would make intrahisian reentry very unlikely. So this is the landmark study of the verapamil sensitive upper septal idiopathic left ventricular tachycardia. It recruits 12 patients, and half the patients has previous catheter ablation of idiopathic LV tachycardia. And in all these 12 patients, they have successful ablation in the left upper middle ventricular septum. So it's a left ventricular type of tachycardia. Now, step 2, how can we differentiate ORT via a nodal fascicular or nodal fascicular pathway from AVNRT or junctional tachycardia? The most important part is that the ORT is a macro reentry circuit. Now, these are the diagrammatic representation, AVNRT with upper common pathway block, junctional tachycardia, or nodal fascicular or nodal ventricular ORT, which the pathway acts as the retrograde limb of the tachycardia circuit. Because this is a macro reentry mechanism for ORT via nodal fascicular or nodal ventricular pathway, as in this example, the tachycardia can continue with VA block because atrium is not a mandatory part of the circuit. And if we can scan the PVC during the His refractories, it's possible to advance the next His. So when we scan the His during tachycardia and and the PVC occurs at the His in the His refractory interval, it actually can advance the next His, which signify that the signal travels through the pathway as the retrograde limb and affect the next His. Another phenomenon in this example is that there will be possible of orthodromic activation of the His bundle after V2, after extra ventricular stimuli. It's also consistent with a retrograde conduction over nodoventricular or nodovesicular pathway and antegrade conduction over the His bundle. So the V2, the extra stimuli, travel retrogradely through the accessory pathway and capture the His antegrade, as this example that the His conduction activation is from proximal to distal, that is the antegrade capture of the His bundle. Another phenomenon is that, as in this example, a left side nodoventricular pathway with increased VA time during ipsilateral, that is left bundle branch block. While in this example, the VA time with the aberrancy is 84, more or less the same with right bundle branch block, but with left bundle branch block, the VA time increased to 120 because with the left bundle branch block, the signal has to travel to the right ventricle and transseptal to the left side, making the tachycardia circuit longer and takes more time to travel from the ventricle to the atrium. So in summary, in step 2, when we try to differentiate ORT with a concealed nodoventricular or nodovesicular pathway from AVNRT or junctional tachycardia, we can see a number of phenomenon. PVC, premature ventricular contractions during His refractory, can advance or delay the next His or terminate tachycardia, that it can influence the next His. And antegrade His capture during RV overdrive pacing. Tachycardia cycle length or VA time can have prolongation during ipsilateral bundle branch block. And the His overdrive, you can also try His overdrive pacing with entry into the tachycardia circuit within 1 beat because of the geographic proximity of the pacing site and the circuit. Now, all these are not present in AVNRT or junctional tachycardia, and that step 2 can help to differentiate these two groups. Now, how about step 3? How about the next step is to differentiate between AVNRT and junctional tachycardia. Again, the main difference is in the underlying mechanism. For AVNRT with upper common pathway block is a re-entry mechanism, and is a micro re-entry mechanism and typically initiated by programmed stimulation. But for junctional tachycardia, it's a non-re-entry mechanism. It can have abnormal automaticity or triggered activity, and is typically initiated by rapid atrial or ventricular pacing or by isoprenoline infusion. Now, how to differentiate between these two tachycardia? We can try the differentiation mainly by premature atrial contraction response, the PAC response, or secondly by atrial overdrive pacing. Now, this is the landmark study that tried to differentiate these two tachycardia mechanisms based on response to atrial extra stimuli pacing that appeared in JACC in 2008. Now, when we try to have the response to PAC, we can deliver the PAC when the junction is refractory. Now, for junctional tachycardia, the PAC would be unable to influence the immediate or the next junctional beat because it cannot penetrate. So during the AV node refractory. But for AVNRT, the PAC can influence the next bit of AVNRT by early engagement of the slow pathway and advance the next His in this diagram. Actually, if it can delay the next beat or termination of the tachycardia, it's also specific to AVNRT. That is, in some sense, it can influence the next beat, then it can differentiate from junctional tachycardia. Now, when the PAC gets earlier and early, then it can influence both junctional tachycardia and AVNRT, but in different ways. For junctional tachycardia, an early PAC advances the immediate junctional tachycardia beat or the immediate hiss by AVNRT fast pathway activation, and then the junctional tachycardia continues. So for early PAC, it can affect junctional tachycardia by advancing the hiss. For AVNRT, an early PAC again may advance the immediate hiss by activation of the AV node fast pathway. This makes the fast pathway refractory and unavailable for the retrograde conduction, and then it terminates the tachycardia. So earlier PAC can affect both tachycardia, but in different ways. Now you can see the intracardiogram. When the PAC is delivered when the junction is refractory, say for AVNRT, this is the PAC, and you can see that in this PAC, the atrium activation coincides with the H, with the hiss. So when we measure the next hiss, it is pulled in. So the PAC time to hiss refractory can advance the next hiss, in this case by 30 milliseconds, indicating that is AVNRT. But for junctional tachycardia, as depicted previously, PAC is unable to influence the immediate or the next junctional beat. Now, how about response to earlier PAC? In junctional tachycardia, when the PAC is early enough, that is, the atrial activation is here, which is earlier than the hiss, and it can advance the next hiss by 44 milliseconds. That is this, the next hiss by 44 milliseconds, and the tachycardia continues, indicating its junctional tachycardia. Earlier PAC can also affect the AVNRT by activation of the fast pathway, making it refractory and terminating the tachycardia. So this differentiating response can tell the difference between the two mechanisms. The second is the atrial overdrive pacing. Well, for AVNRT, the atrial overdrive pacing can transiently entrain the tachycardia with continuation of the tachycardia after cessation of pacing, well, what we call an AHA response. But for junctional tachycardia, the atrial overdrive pacing will suppress the junctional tachycardia focus with immediate resumption of the tachycardia after cessation of pacing. And the first return beat is a junctional beat led by the hiss signal, what we call an AHA response. When we look at the return beat for AVNRT, because of the reentry mechanism, there would be fixed VA interval of the first tachycardia beat or return cycle length, what we call the VA linkage, which is not pleasant in junctional tachycardia with variable VA interval. Diagrammatic representation, this is the pacing beat, and we can entraining beat. So this is the large entrained pacing, and you can see that when the first return beat comes for AVNRT, this would be a AHA response. But for junctional tachycardia, it will suppress the tachycardia circuit. When the first beat comes, it would led by the hiss, and this is the first return beat, and you can see it would be a AHA response, which is different between the two. Now, there are some important remarks for the above discussion. The pacing maneuver mentioned above are not exhaustive, and some tests are established based on studies with relatively small sample size or very selected patient group that may not be generalized. And some tests are modified after original publication. And there are also exceptions on very challenging scenarios, though where, for example, an AVNRT with bystander nodoventricular nodovascular pathway or versus a real nodoventricular or nodovascular ORT. And there are simultaneous adequate, fast, and slow pathway conduction in AVNRT during response to PAC. It can mimic junctional tachycardia with continuation of tachycardia, what we call the double firing effect. Now, for summary, for narrow complex tachycardia with VA dissociation, we know that the atrium is not part of the circuit, so it would exclude atrial tachycardia or ORT using a conventional or atrioventricular pathway. And the first step, we see the VT, the upper septal idiopathic left ventricular tachycardia, is always the HV in the VT is less than HV in sinus. And the absence of split His potential makes intra-Hisian re-entry very unlikely. And then step 2, we can differentiate ORT via concealed nodoventricular nodovascular pathway against AVNRT or junctional tachycardia. A number of phenomena that we can observe. PVC during his refractoriness can reset or terminate tachycardia. Antiquate his capture during RV overdrive pacing. And tachycardia cycling for VA prolongation with ipsilateral bundle branch block or his overdrive pacing. And then step 3, and we differentiate the AVNRT against junctional tachycardia. We can use premature atrial contraction response. We can throw in atrial PACs, or we can use atrial overdrive pacing and see the response of the tachycardia after cessation of pacing. So this would end my talk. Thank you.